This is the summary of electrolytes mastery, or the mini master that had conducted like a year back. My first talk would be about calcium. Starting with hypocalcemia, low PTH, hypoparathyroidism would be because of any one of these, like genetic disorders. The parathyroid gland did not develop yet, or enough abnormal PTH synthesis, or there is mutation in the calcium sensing receptors. You know, these calcium sensing receptors are important to regulate the PTH secretion. Whenever the calcium level is fine, so this would, the calcium will bind these receptors to, reduce the PTH secretion. Or post-surgical, of course, some autoimmune diseases, as you know, the autoimmune polyglandular syndromes and isolated hypopara, infiltrative diseases, whatever, like granulomatous diseases or metastasis, or even HIV infection can do this. The high PTH, it could be most of the time is secondary to vitamin D deficiency. So when you see like PTH, high PTH, the first thing you should look for is the level of vitamin D. We're talking about the 25 hydroxyvitamin D in a patient who is having normal kidney function, but of course, if there is a problem in the kidney function, the 125 as well is playing major role. So the vitamin D deficiency or resistance, PTH resistance itself, that might be related to hypomagnesemia. We'll talk about this in the coming slides. Kidney diseases, and list is long. Drugs as well. Some of these drugs are well known to us, like cinacalcet, and some of them we even don't think about, like phenytoin, because it affects the convergent vitamin D. It pushes it for render it inactive, in fact. The magnesium, as we said, we'll talk about. What hormones, when you understand the hormones related to calcium, that is the time that you will know what's going on when you see hypocalcemia. So the main two hormones are like PTH and fibroblast growth factor 23. Usually we call it like FGF23. And they both are phosphatidyluric hormones. They secrete phosphate, but they affect the calcium in different ways. Parathyroid, we'll see it in a minute, but FGF23, it inactivates, or it actually affects the activation of 125 vitamin D. So if 125 is not there, this means that the calcium homeostasis would be affected. Yeah. As you know, that vitamin D is important in different places, mainly the gut absorption of calcium. And PTH is important in reabsorbing calcium from the kidney, and increase intestinal calcium absorption as well, because it enhances the activation of 125 hydroxyvitamin D, and that's in fact is what we just said, is opposite what FGF23 is doing. And of course, it does increase bone resorption. So what we do if we have patients with hypocalcemia, the most important things, I need to be a bit fast because the slides are like a bit lengthy. Whenever you have a patient with hypocalcemia, you ask yourself, what is the emergency? Is there something that I have to act urgently? Like presence of life-threatening condition, carpopedal spasm, laryngospasm, bronchospasm, seizure, or there is ECG changes by prolonged QT interval. So are these there? Any one of these are there? If it is yes, sorry. If it is no, then you have to ask yourself: is your patient asymptomatic? or mildly symptomatic. It means that there is an acute hypocalcemia, effect. Is it there or not? So if it is not there, it means that your patient is asymptomatic, or there might be mild symptoms. Most of the time, it's because of chronic hypocalcemia. So this does not need most of the time IV calcium. They need just an oral calcium. The otherwise, if your patient is having some sort of symptoms, it means there is acute symptoms. Then it depends. Those symptoms are not life-threatening, but the level is like more than 1.9 millimole, or the ionized calcium is 0.8 millimole, then most of the time, again, you don't need IV calcium. But if it is less than that, yes, or there is life-threatening condition, at those times, you need to go for IV calcium. So if you need to give oral calcium, the oral calcium supplement, for we're talking about acute hypocalcemia with mild symptoms and calcium level above 1.9 millimole. So those are the ones that you could give them oral calcium. And when you give them, you test your retest your calcium level within 24 hours. And for chronic hypocalcemia, you don't need to do it in 24 hours, of course. You would do it after like a week. Then you check the calcium. Did it rise or not? If it did rise, then you will continue the same. If it did not rise, you will increase your calcium level, calcium supplements by 1 to 2 grams of the elemental calcium. If there is no improvement, you switch to IV calcium. But those patients who have life-threatening conditions or the calcium level that is below 1.9, then you could consider the IV calcium. When you give IV calcium, you check more frequently, like every 6 to 8, or yes, 4 to 6 hours, sorry. And then you check magnesium as well. You check magnesium. We'll talk about this. Solution that you use to prepare the calcium. All of us were familiar with calcium gluconate. Maybe calcium chloride. Mostly it's not available in our institutes, but calcium gluconate is well known. And the difference is that the calcium gluconate has only 90 milligrams of elemental calcium compared to the calcium chloride. That is 270, 3 times more. This will make calcium chloride, very irritant if it is used in the peripheral line. That's why you need to use it in the central line. And when you need to replete the hypocalcemic patients, you need to give good dose of calcium, like 1 gram of the elemental calcium. It means that you need 11 grams of calcium gluconate, for instance, and you dilute it in dextrose or or saline. When you do this mixture, this solution almost you're making like 1-to-1, 1 milligram per ml. That's when you give 50 ml as if you're giving like 50 milligrams. Yeah. So the no bicarbonate or phosphate, fluid containing, solutions, because the calcium will bind those and precipitate. So you start your patient with, calcium. You make sure that the vitamin D is on board. So calcitriol usually is a good to start with because it has rapid onset of action. The hypercalcemia is, this is very well known that the hypercalcemia could be either because primary hyperpara or malignancy. The difference between the two is not that difficult to notice because Primary hyperpara, usually mild hypercalcemia, usually below like 13 milligram, compared to malignancy is higher. The primary hyperpara, long-standing, they have they are asymptomatic most of the time, and compared to the symptomatic patients with malignancy, they are healthy outpatient compared to hospitalized patient. And the typical example is for para is postmenopausal women with normal physical exam, and maybe they have some sort of granulomatous disease like sarcoidosis. Maybe they have family history of hyperpara as well. And compared to malignancy, they manifest rapidly, and the serum calcium, as we said, is high, and they have advanced disease most of the time. And when we go to the causes of hypercalcemia, we could again classify them into parathyroid mediated, like as we just mentioned, the primary hyperpara, and some sort of familial hypocalciuric hypercalcemia. Maybe we'll talk about this very briefly in the coming slides as well. And tertiary hyperpara and renal failure. Non-parathyroid mediated like hypercalcemic malignancy, as just mentioned, vitamin D intoxication, chronic granulomatous disease, again, medications, very well known thiazide, and vitamin A intoxication, in fact, and there are some sort of miscellaneous as well. So what do we do if we have a patient with hypercalcemia? Well, you ask yourself, again, an emergency, does this patient have symptomatic hypercalcemia, or their total calcium is above 14, like or 3.5 millimole per liter? If it is no, then you review the medications. So if the level is not that high, you review the medication that patient is taking and repeat total calcium. And of course, you correct for the ionized calcium to confirm the hypercalcemia. Many patients, they have high albumin because they are volume depleted. We don't correct back down the calcium to see if the calcium is really elevated or not. Hypercalcemia, if it was confirmed, then you measure concomitantly with the as we say, the ionized calcium to check, and you check the intact PTH. If the calcium is above 3.5 millimole, you don't wait. You have to start immediate treatment. And if etiology is unknown, you measure PTH. So what is the PTH? PTH is elevated, so this is most likely primary hyperpara. If it is mid to upper normal or minimally elevated, then it is still primary hyperpara is possible, but you have to consider the familial hypocalciuric hypercalcemia as well. And if it is low normal or low, then primary hyperparathyroidism is unlikely, and you have to evaluate for non-PTH related hypercalcemia. And if it is apparent, you could say this is malignancy, most likely. If it is not apparent, you do the parathyroid hormone-related peptide, and you check for vitamin D, both, in fact, the 125 and 25. So if the PTH-related peptide is, elevated, then this is, malignancy-related. If it is not, then check the 125 vitamin D. If 125 vitamin D is elevated, then lymphoma is possible, granulomatous diseases. If it is not elevated, then you go and check for the 25 hydroxyvitamin D, because vitamin D intoxication is possible. If it is not elevated, then you measure the serum or and urine protein electrophoresis to see the light chains as well. If they are abnormal, so multiple myeloma is in the top of the list. If it is normal, then assess for other diagnoses like vitamin A intoxication or hyperthyroidism. The clinical manifestation are, calcium, if it is high, it will work like Lasix. It would cause, polyuria, then polydipsia, of course, nephrolithiasis, because the calcium is being excreted in high amount that will precipitate, causing that nephrocalcinosis as well. GI effect, the well-known is constipation. The musculoskeletal manifestation of, hypercalcemia is muscle weakness, bone pain, as well neurologic, you have some sort of confusion, and cardiovascular, of course, shortened QT interval is very well known. The first thing you have to start your patient with whenever you have hypercalcemia is isotonic saline hydration, because sodium in saline, whenever it goes to the kidney, takes with it the calcium. So that's why you need to restore the intravascular volume, especially if your patient is, polyuric with calcium. They usually come, volume depleted. You need to push saline, and at the same time, that saline would enhance calcium secretion. Calcitonin is, it works in within 4 to 6 hours. Bisphosphonate, if there is no contraindication, of course, if there is renal impairment. Loop diuretics, well, most of the time you don't need it, unless your patient is volume overloaded. Glucocorticoids, if you're thinking of, a malignancy or like granulomatous diseases, because those, they, in fact, increase the absorption, as we said, of, activation of 125 hydroxyvitamin B that is inhibited by steroids. Denosumab, if you have, renal impairment, we're using it, and we see lots of hypocalcemia, in fact, because of that one. Calcinomimetics, the cinacalcid that we mentioned, of course, dialysis. If your patient is really in bad shape, it's very rarely that you would need to do dialysis for hypercalcemia. When you have mild hypocalcemia, most of the time you don't need to do much. They are asymptomatic, or maybe they're mildly asymptomatic, you don't need to do much. If they have moderate hypercalcemia, like 3.5 millimole per liter, maybe they would be, they might have some symptoms, and then you need to treat them. If the, calcium has acutely raised, and that might cause a problem in their, sensorium. But those patients are the ones that they need aggressive treatment. I'll go to phosphate, and then I'll pause to see if there is any question. Phosphate, when we talk about, it's one of the electrolytes that's mainly intracellular, and mainly it's in the bone. And when we talk about phosphate, the main thing that we talk about is refeeding syndrome. And refeeding syndrome, of course, this not in a patient with advanced CKD. The phosphate in advanced CKD is another story. I'm not talking about it tonight. I'm talking mainly about patients with good kidney function. So patients who are having malnourishment, they are in a catabolic state. The insulin level is very low. Glucagon is high. So the glycogenolysis is augmented, protein catabolism is high, gluconeogenesis is high, vitamin and mineral nutrients are very low. The refeeding happens whenever you introduce the carbohydrates, and that will urge the insulin to be secreted. This will start the cascade of, anabolism, like protein synthesis, sodium retention, that will increase even the extracellular volume. Glucose would be taken inside the cells, as well as, phosphate as well, not just glucose, and thiamine would be used if there is thiamine, of course. And the shift of all those elements are the main reason for, refeeding syndrome. And phosphate specifically is one of the main reasons. And the main killer, in fact, for the refeeding syndrome is, the cardiac manifestation. They do like develop heart failure. You should know the replacement. We'll talk about this in the coming slides. The major causes for hypophosphatemia to start with is increase in insulin, acute respiratory alkalosis, and this acute respiratory alkalosis, put it in your mind, it's the main reason for hypophosphatemia for hospitalized patients. In fact, hungry bone syndrome, decreased intestinal absorption because inadequate intake, inhibition of phosphate absorption by antacid, mainly the aluminum containing antacids, and steatorrhea, diarrhea as well, vitamin D deficiency, because it's needed for phosphate absorption. And there is an increase, urinary excretion of phosphate. As we said initially, that PTH is phosphatidyluric hormone. So PTH is a main reason, high PTH for hypophosphatemia. And the other thing is Fanconi syndrome. I think there is a slide talking about Fanconi. We'll talk about this later. Some medications like acetazolamide, tenofovir as well. Yeah, this is Fanconi. So Fanconi is a problem in the proximal tubular function. Hypophosphatemia is the main player in there, and all of those like elements would be lost in the urine: glucose, uric acid, amino acids, and there is proximal renal tubular acidosis as well. And multiple myeloma might be a reason for Fanconi syndrome. So if you have glucosuria for a patient who is not diabetic, who is not using, of course, SGLT2 inhibitors. So those patients, you see glucose, that might be a very bad sign. Medications like antiretroviral, like tenofovir, and in children, some of these could cause as well Fanconi syndrome. Symptoms of hypophosphatemia, like sinus symptoms, encephalopathy, down to hallucination and paresthesias. There is chance of hemolysis and thrombocytopenia as well because of phosphate. This is very weird, right? And the cardiac manifestation, depressed cardiac contractility. That's why we said the killer is there in the heart. Arrhythmias and heart failure, rickets. Of course, there is no phosphate stimulation, growth retardation, proximal myopathy, rhabdomyolysis. It's caused by hypophosphatemia is the reason for rhabdomyolysis. Hypokalemia is a reason for rhabdomyolysis. And if you're having sickle cell trait as well, it's a risk factor. How do we know where is the phosphate is going? Is it in GI or it is going in the urine? It depends on the fractional excretion. If it is below 5%, so it's not because of the kidney, it is because of the GI, either because of inadequate intake or there's chronic diarrhea, antacids that we talk about, PPIs, or there is transcellular shift because of high insulin surge, refeeding, glycolysis stimulation, hungry bone, as we said before. And if it is more than 5% fractional excretion, means the kidney is the culprit. And you need to know the reason for that is the PTH is high. Are you using those bisphosphonates, denosumab, even estrogen could cause this? High PTH. Or if PTH is normal or low, then you think of, is it related to the FGF23? So FGF23, as we said, it's phosphatidyluric hormone. It pushes phosphate outside through the urine. And even using carboxymaltose could raise FGF23 and could cause some sort of hypophosphatemia. If FGF23 is high, so maybe one of those are there. If it is normal or low, maybe Fanconi is in the top of the list. How does phosphate affect the, you know, oxygenation and, you know, it says here that the main reason for extraskeletal effect of hypophosphatemia is because of two things. You know, remember this oxygen dissociation care, diphosphoglycerate DPG or 2,3 DPG level. Whenever it is low, this will drive the curve to the left. So will make hemoglobin very avid to the oxygen. It wouldn't give oxygen easily, and this is a problem. And low phosphate does this. This is one. The second thing, of course, if the ATP inside the cell is low, so the cellular function will be like paralyzed. How do we treat? It depends on the level and symptoms. If the level is like 0.64, just below the normal, that is 0.8 to 1.5 millimole per liter, most of them, they are asymptomatic. So if they have some symptoms, the oral phosphate should be fine. And if you want to use the, or you need to use the, oral phosphate, it should be like the patient phosphate is between 0.32 to 0.63, not below 0.32. If it is below 0.3, you should give IV phosphate. And whenever you reach like phosphate close to 0.64, you should stop IV. You should just depend on the oral. The oral dose is 30 to 80 millimole. You could use this regimen if phosphate is above 0.48. You give 1 millimole per kg of elemental phosphorus, like 40 to 80 millimole. If it is less than this, you can go up to 100 millimole. This is when we talk about the oral, and you check after 2 to 12 hours following the last dose. The intravenous is potentially dangerous because it might precipitate with calcium and it might cause arrhythmia. So you avoid it whenever you can, especially if as we said, if phosphate is above like 0.4 or so, there are not much symptoms. You don't need to rush. But if your patient is having some sort of symptoms, or you are a bit afraid that the oral wouldn't be enough, you could give up to 0.24 millimole per kg over 6 hours. The maximum up to 30. But if the serum phosphate is less than 0.4, you could go up to 0.5 millimole per kg, like up to 80 millimole. Of course, it will be slower, over 8 to 12 hours. Hyperphosphatemia. We don't talk much about hyperphosphatemias because usually these patients has renal problems and the treatment is a bit hectic for you. Yeah, so the acute phosphate load, whenever you have significant hyperphosphatemia, you have to think of, lysis, either tumor lysis or rhabdomyolysis, because as we said that the phosphate is intracellular. Yeah, so the cell lysis, phosphate-containing medication, laxatives, the platinum has good amount of phosphate. Lactic acidosis could cause cellular shift and could cause, hyperphosphatemia, and of course, acute kidney injury or chronic kidney injury as well. For the time, I'll skip those. The treatment is, if we're talking about acute, raise in phosphate and the kidney function is fine, just wait, replete the volume for your patient, and the kidney will take care of that phosphate within like 6 to 12 hours. If kidney function, as we said, is intact, you give saline, that will enhance, getting rid of hyperphosphatemia. If the hyperphosphatemia is a chronic and the kidney function is impaired, like hemodialysis would be the best anyways. But before hemodialysis, you do diet restriction and you give like phosphate binders, and phosphate binders are either like calcium based or non-calcium based, like sibylline.